so we flip this around, cords fly everywhere. But you have 180 highly motivated and interested people here with you today.
That's great. So can you hear me? It's very strange to talk into a disembodied audience, but I'm going to take your word for it that you're actually there. It's also kind of weird to use technology to talk about the abnormality and make use of technology, but we're going to suspend that for now as well. So I'm here to talk a little bit about, on a clinical and psychiatric level, what some of the things we see with technology. And my background comes both in part from a research perspective as well as a clinical one. And I'm going to sort of dovetail back and forth between those. One of the things that I want to start with is that I did a recent study in collaboration with AT&T, and I was very interested in the sort of parallels between the general field of internet addiction, which is where I started my work. Of course, when I started this research and work in the late 90s, we didn't have smartphones. And my original research, which was published in 99, found about 6% of people meet the criteria for internet addiction. Now, those criteria are very similar to the criteria that Dr. just talked about. But what was interesting was I tried to replicate and update some of that work in our recent research with AT&T. And that number, with regard to smartphones, is about double. So now we've gone from about 6% to about 12%. And I think that's probably a conservative estimate. Whether that's being driven by FOMO, fear of missing out, whether it's being driven by other criteria, which I'll mention in terms of etiology and epidemiology, we're not sure. But clearly there's something going on here that leads me to believe that essentially the smartphone is the world's smallest slot machine. That we have taken the dopaminergically elevating capacity of the internet, we've miniaturized it, portabilized it, untethered it, and put it in our pockets, and now we've got it in our cars. We've made some attempts to limit the use and abuse of that technology through some of the new texting and driving laws. But this leads me to another issue. I theorized that I didn't think that what people were doing necessarily in their cars was just texting. And in fact, in some revised research that we just looked at, that's in fact been the case. People are not just texting. What they're doing essentially is everything that they would do with their smartphone on land or while they're walking, but they're doing it while they're driving. And that includes taking selfies, searching, emailing, social media. It doesn't really matter. They're using all of the features on their smartphone while they're driving. Texting happens to be one of the more frequent ones, and that's where the research originally started. But I think it's important to know that it's not just about texting. Why is that relevant? Because the laws that we have on the books right now really are specific to texting. Ultimately, I think we're going to have to look at smartphone use in the automobile. It's not good enough to just look at the issue of texting. So let me talk a little bit about some of the qualities that we find. One of the interesting things that we looked at, and that I've looked at both clinically as well as in some of the research, is this broadcast normalcy. And Paul, you just alluded to that before. There's this belief, and I don't think it's really just attitudinal. I think it's changed the norm within the Generation Z group. These are 25 and under people. People who have grown up with this technology, who have not really been around without it. If they experience something and they don't record it and broadcast it, it's as if it didn't happen. So there is an expectation in the now that if it's not recorded and broadcast, it didn't occur. So that's part of a compelling reason to continue to use the smartphone. So it's not just that they want to communicate, it's that they want to express what they did, because if they don't, it didn't happen. So that's one of the things that we found. The other interesting thing that we found in some of the clinical population that we interviewed all of our patients, and one of the things that we asked them is about their level of perceived impairment with regard to their use. Now, this isn't a well-controlled research study, but it's more anecdotal. And what we have found is that people's perceptions of the level of intoxication or impairment, for lack of a better word, while they're driving is distorted in a similar way to the original research that people would misperceive the level of impairment as their intoxication level increased. And we're seeing the same thing. Similar to what you were talking about with regard to distortion of time. By the way, the time distortion feature is something we found back in the late 90s with the internet. We found that 80+% of people cannot accurately perceive the passage of time when they're using digital media, or particularly anything that accesses the internet. Remember, the smartphone is just the latest and greatest and most portabilized version of an internet portal. It's just another way of accessing the internet. I also don't know how much time I have, because I don't, so keep me posted. Okay, great. So time distortion and dissociation is a big feature. The other thing is we have a tremendous distortion in what I call delusional multitasking, which is this idea that, in fact, you can do multiple behaviors simultaneously. And I think most people in the audience know that the research is pretty clear on multitasking, that that doesn't exist. With this population of people that I treat, that distortion seems to be more acute. Now, I will tell you that in terms of on the treatment level, people do not come in for treatment generally because they have a self-perceived problem with regard to their use. They come in for the same reasons they come in for any addiction medicine treatment, and that is they either got caught doing something, there was a legal consequence, there was a marital or relational consequence, or there was a job consequence. The last one is consequence with regard to their school behavior. So I would say that's the largest consequence, is a reduction in academic or work performance, or followed by a consequence legally. But in general, there is a perception of normalcy that this is the way life goes on, and if we get caught or something happens, then we'll get treatment. People do not self-present. They do not come in because they think they have a problem. They come in because the problem has found them, and they need to do something about it. Once they receive treatment through various motivational techniques, they do perceive it differently and they do change their behavior. But it's not until they reach that point of critical mass that they actually change that attitude. I'm not going to talk a lot about instant gratification, but what seems to happen is that we've changed the communicational currency. I agree with some of the earlier comments that were made, that the concept of now has changed, that the idea that if you don't respond immediately, that response becomes irrelevant. So we have to look at this behavior with a new framework, because we're looking at it with a voice technology telephone modality, but this technology is not a telephone. It's really, in my way of thinking, it is a hypodermic connected to dopaminergic innervation that people have in their hand. And all the research we've done on dopaminergic innervation shows that if you give people the ability to control that innervation, they will use it forever. And they will use it frequently, and they will use it to a point of exhaustion, and they will use it to a point of self-detriment. So I think we have to start thinking in terms of this being a drug of choice and a drug. Mind you, the smartphone and all elements of the internet, but the smartphone in particular, is a psychoactive medium, and it is a drug. It's a drug for everybody, but not everybody abuses it, just like not everybody abuses drugs. And as I said, I'm putting the number at about 12%. The other issue that has probably been alluded to throughout the morning is the degree of cognitive dissonance. So the idea is that people not only distort time, but they distort their perception of their impairment, and they change their attribution of their motivation with regard to contributing to that impairment. In other words, they say that I'll just answer this one text or respond to this one thing, but it won't be a problem. And in fact, when you point out the reality of the facts of how that impairment will occur, then and only then will they actually see it. So there's a constant element of dissonance with regard to their behavior and their potential impairment. Let's talk a little bit about notifications for a minute, because I think notifications are really key. You know, one of the things that people, that we teach patients, and that was alluded to earlier, is that notifications are a big trigger. So with all addictions, we look at trigger behavior. We look at what gets them to push the button to either take the drug, take the drink, or in this case, use the smartphone while they're driving. And notifications are a big issue with regard to that trigger response. But what's really interesting about notifications is you can turn them on. So a big part, and a lot of people don't talk about that. So one of the first things, of course, we talk about is turning off notifications. Because if you turn off the notification, what you've done is you've removed that classical connection to the operant reward loop that activates that dopaminergic innervation. And we're talking about microbursts of dopamine. But think about how many microbursts of dopamine are occurring in an average day with the smartphone. And part of the issue that we're talking about is variable ratio reinforcement. One of the things that we looked at very early on is that the smartphone, the internet in general, operate on that variable ratio reinforcement schedule. Think about the internet, think about the smartphone. You don't know what you're going to find if you're doing a search. You don't know what you're going to find if you check your social media. Every text is a new opportunity to roll the dice. It may be something interesting. Every email, it may be something interesting. It may not be. Because of that unpredictability and variability, that's what keeps that person continuing to go on and look for that hit. It's the variability and unpredictability that produce that behavior that we call addiction or that we call compulsion. It's not rational, it's biochemical. In fact, I think this is more neurologic than psychologic. I don't think people are really, if you ask them their attitudes, they'll come up with answers, but I think what's really operating is it makes them feel good on a subconscious level, and they want to continue to feel good, and that's why they're doing it, ultimately. So a big part of education is teaching people about the neurobiology. So we talk a lot about that reward circuitry in the brain, and teach them how that mesolimbic system works, and why they're using it. And it really does help educate people with regard to their use. Pharmacologically, not a lot you can do with regard to that. There's some evidence that Wellbutrin and some of the more dopaminergically sensitive drugs can help. But in general, this is a behavioral addiction. Like many addictions, it has to be treated behaviorally along with other concomitant psychiatric issues. Another interesting thing that we postulated, earlier was latency speed. So this is something that we've been tracking for a long time, since the late 90s. I postulated early on that we know that substances that produce intoxication increase in their addictive potential based on how quickly that substance enters the bloodstream. So what we looked at initially was, well, how does that relate to the smartphone? Based on that, if a signal is produced and information is received quickly, or more quickly, is that going to increase the addictive potential of that behavior? And in fact, that's what we found. So the numbers that we're getting now looking at this behavior in our clinical population as well as in our research are far greater than the numbers we got in the late 1990s, and that's why that number is creeping up, I believe. Because speed of internet access has increased, the latency between the button push and the piece of information that's following that button push is much shorter. And if you think about it again on a neurobiologic level, that makes perfect sense. That less time has elapsed between the behavior and the intoxication, although it's small, which is going to increase the likelihood of that addictive potential. So my fear is, and I think this has been borne out by what we're seeing in the general population as well as in our clinical population, is that more people are using these technologies compulsively than ever, and portabilizing it and untethering it just increases that accessibility. Because one of the things we looked at initially back in the 90s was that accessibility was a big factor in predicting addictive potential. Now we've taken that accessibility, we've put it in our pockets and now in our cars. Why would we stop using it simply because we're moving in a vehicle? We're thinking logically, but you can't think logically. You have to think on a neurochemical level that if something feels good, people are going to do it. Same thing that we're seeing with diet and eating behavior. Why do people eat those high caloric foods? Because they feel good and they taste good. And the consequences are not perceived as relevant to them, or they're not conscious of them at the time. Same behavior that we're seeing with a smartphone. So one of the takeaways that I want to emphasize is we're not just talking about using everything on the smartphone. So we really need to think of the smartphone as just an extension of the internet, a small computer that's now in your car, providing all of the world's most intoxicating content and easily accessible and producing information at a very fast pace. How can we get people to stop doing that if it's dangerous? I think that's a challenge, and that's what I'm going to leave you with. I thank you for your attention. I'm sorry for rushing through, and thank you.
Great, thank you. I want to thank David and all of our speakers today. And we've had 2 Skype sessions that actually worked with the sound and everything. So I'd like to thank Rich, Kristen, and everyone that's managed to make all this happen. So give them a round of applause.